in there. Before we even left on spring break about coronavirus, I had no idea what it was at that time. I do know that there were some other well-known things, SARS and MERS. Those were other coronaviruses. I mean, a cold is caused by a coronavirus. So anyway, we're in the thick of it. You probably know much, much, much more about it, at least as much as me, just if you're watching the news, which I almost can't stand to watch it anymore. But anyway, so that's about coronavirus. Don't worry, none on the exam. So we are going to start out with influenza. So first of all, so what is influenza? Well, it's a highly contagious respiratory illness, right? And the typical flu season is in the wintertime. So this kind of is going along with what the coronavirus is doing to us at this time. Current thinking is the reason that it peaks in those months is because we're all in a confined space, right? We're all packed in together, the cold weather. We're not going outside and doing anything. So flu season, April, peaking in November, 250,000 people get hospitalized. That 80,000 deaths, I think it's more up to like close to 100,000 people die every year from flu. And speaking of flu, it's a lot of people say it, and I do it too. So they say the flu. Well, it's really just flu. You don't get the cancer or don't have the diabetes, right? It's just flu. But anyway, we all do it. So just kind of a small thing. So the etiology pathophysiology is classified into 3 different types, right? And a virus mutates it, which is another thing about the coronavirus, is they're showing that it's mutating too. But that's why we have to get a flu shot every single year, because it mutates while it's not here with us. Only A and B cause significant illness in humans. So we'll talk about influenza A, by far the most common. It's also the most virulent, right? Which means it's the thing that's most spread most often. It can spread from animals to humans. Can be known to cause a pandemic. So obviously we're in a pandemic. So an epidemic is a disease that affects a greater number of people than is usual for a locality, or spreads to areas that aren't normally associated with the particular disease. A pandemic is basically an epidemic of worldwide proportions, right? And obviously that's what coronavirus is. So 75% of the confirmed seasonal infections are due to influenza. So influenza A, it's a subtype into H and N, the hemagglutinin and the neuraminase. I'm sure I'm mispronouncing that, but the things that we saw most often were the H1N1 and the H5N1. Don't worry, you're not going to have to remember these as far as that goes. I think it's more just let you know that that's what they're called, right? So right now, so the H1N1 was the swine flu, and the H5N1 was bird flu. That came from Asia as well. So I don't want Asians to get a bad rap. It just happens to manifest there first, and that's just the way it goes. So etiology, pathophysiology of influenza B, right? Similar to A, but it's only spread human to human, right? It causes those seasonal outbreaks that we see through the wintertime. However, you can get influenza B anytime throughout the year, right? Also, influenza C, the mildest version, most people just think they have a cold, right? They don't even worry about it. They might go, oh, I got a little bit of a sore throat. I feel kind of down a little bit, so that's what that is. So several strains of the influenza virus exist. It mutates over time. Each flu season is different. And then that's why you have to get, again, that annual vaccine. So where do we get that? It takes a long time to grow a vaccine, which is like for coronavirus. I guess I'm going to mention that quite a bit. It takes 12 to 18 months for them to come up with the vaccine for something like that. So, and that's because what they do is they look at the southern hemisphere. Of course, they're having their winter when we're having our summer. And they kind of look and see what's going on, what's becoming prevalent down there. And then we kind of come up with what we think is going to be happening here up in the northern hemisphere. And that's the way they go around doing it. So, moving on. So how is it transmitted? Well, person to person through droplets and the inhalation of those particles. And that's the other thing. Coronavirus is droplet. They're not sure how long it can stay alive. I saw something just the other day on cardboard for 24 hours, on plastic or metal for up to 7 days. but typically it's through droplet, right? So, and that's why that 6 feet distance thing is going on for coronavirus. Do the same thing for flu, right? So you inhale those particles, they set up house, and 1 to 4 days later, you end up developing influenza. Peak transmission is typically 1 day before the symptoms appear, and it can continue for 5 to 7 days after you first start showing symptoms. So you're still going to be sharing with everybody. And this is one of those few cases where sharing is not caring. So the clinical manifestations of flu, usually the onset's abrupt, right? It happens almost right away. This isn't something that grows. I feel bad for typically a few days, but it comes on almost overnight. Fever, chills, myalgia, so there's generalized muscle aches and pains. You might get a headache, talking about sore throat, fatigue, you just don't feel like you have any energy. And the symptoms usually go away 7 days later or so. Now that's not the same for everybody, just because, obviously it affects some people worse than others. And a lot of that has to do with your general body habitus, your general health status, and those kinds of things. So here's a picture just kind of showing some of the symptoms of influenza. So you kind of get an idea of what's going on with that. And you can see where, this and coronavirus, they kind of tend to mimic each other. And a lot of people like to have flu or have the coronavirus. I don't know. So cold or flu. So this is, again, symptoms of cold versus flu. Onset, abrupt for flu. Cold tends to come on more gradual. This is just kind of something you can kind of look at. Don't worry, I'm not going to ask you to compare cold and flu on the exam. So, so how do we diagnose? Well, a lot of it is based on your history. What's been going on, right? So where have you been? What have you done? They do some viral cultures that can take up to 3 to 10 days for the exact thing, but they can identify what strain is it. Is it an H1N1 or H5N1, something like that. There is also a rapid influenza test that can be done. It's available from your primary care physician. You get results in about a half an hour. Useful to differentiate flu from other infections. Is it cold? Is it a flu? Is it pneumonia or something like that? Diagnosis is often missed because a lot of false positives happen quite a bit. We always want to follow up with a rapid influenza molecular assay. So some of the complications of flu, well, it can develop into pneumonia, right? So you become dyspneic, you get crackles, are an early sign that your pulmonary system is starting to get involved. Ear and sinus infections are fairly common, as well as you become dehydrated. And a lot of that is just because that general malaise, particularly in older adults, we were talking about with fluid and electrolytes, how they just tend to not, they're not hungry, they don't want to eat. So. Boy, this thing didn't transfer over too well. But anyway, so how do we treat influenza? So, well, prevention is the best, right? Just don't get it, right? Get a flu shot, wash your hands, don't touch your face, all the stuff that we're hearing on a regular basis here today. So quit smoking, obviously. Stay at home if you feel like you have flu-like symptoms, right? And just avoid those people that do. Frequent hand washing, keep your hands away, avoid close contact, and get your flu shot, right? Always a good idea every single year. I think a lot of people don't get it. We all do because we're healthcare workers, but I think a lot of us, I don't think I got one before I became a nurse, but anyway, so that's the deal with that. So you can get a trivalent inactivated influenza vaccine. You get it as an injection. It's an IM injection. Approved for anybody 6 months of a year, pregnant women. In fact, pregnant women should get a flu shot. They are good for immunocompromised persons or residents of nursing homes. A lot of people feel like they're like, well, I think I never get a flu shot because it always gives me the flu. And it's just not possible, right? It's an inactivated, right? It's inactivated. It's a dead virus, right? But your body senses it, and then it builds up the antibodies for that particular strain that you happen to be getting the vaccine for. Common side effects, of course, fatigue, low-grade fever, something around 100, 100.5, something like that. Headache, the injection site might get some redness, painful, swelling, and it's not that big a deal. So there's also a live virus that you can get, LSIV. It's so those that are just really freaked out by needles, they just can't take it. It's given nasally, healthy people only from 2 to 49 years old. So if you're 50 or older, not so good for you. But not given to anybody less than 2 if you're known to be immunocompromised, because again, it's a live virus, right? And also children or adolescents that are receiving aspirin or salicylates as a part of whatever's going on with them for their treatment, right? That can touch off Reye's syndrome. So common side effects, of course, are runny nose. This is a live virus, so it does give you a touch of what might feel like the flu. So anyway, sore throat in adults and fever in children that are younger. So, and that's pretty much it for influenza. So let's go on. Let's talk about pneumonia. PNA, that's the way we usually abbreviate it. You can come up with your own, but if you're going to write into a chart, PNA is kind of generally accepted. So what is pneumonia, right? So it's an acute infection of the lung parenchyma. So what is the parenchyma? That's just the functional portion of an organ, right? So in this case, the functional portion of the lung. It's associated with significant morbidity and mortality rates, and pneumonia and influenza. They combined are the 8th leading cause of death here in the United States. So likely to result when the defense mechanisms become incompetent or overwhelmed. So something is happening in your generalized health status where all of a sudden you can't fight off these infections that you could in the past, right? One of them is air filtration, right? So we filter air through our nose, right? Through the hairs in our nose. Some people are filtering better than others. Maybe the mucus that's in our nose and also in our airways, it traps the molecules of the bacteria as it's going down, or the virus. Maybe the epiglottis closure over the trachea, the cough reflex, maybe it's impaired for whatever reason. You're older, you're ill, you're infirm, you're not able to generate a good strong cough. That mucociliary escalator mechanism, that's the thing that's constantly happening. That's why we suddenly have to clear our throats every now and then. This really gets affected when smokers kind of tend to get off on there. And then a reflex bronchoconstriction. So that can be like either hot or cold air. Maybe it's the pollution that you're coming in contact with. So that decreased cough and epiglottal reflexes may allow aspiration. And that's when you get, and we'll talk about in a second here, but you get aspiration pneumonia. So again, the etiology, that mucociliary mechanism gets impaired, pollution, those smokers, upper respiratory tract infections that are happening, people get intubated, tracheal, we'll talk about trachs here a little bit, and also aging. Again, aging kind of slows down your responses to anything. Most chronic diseases suppress the immune system in some way or another. So 3 ways that organisms reach the lungs, right? Either through aspiration, through your nose or your oral airway. Those microbes that are present in the air, and homogeneous spread from an infection somewhere else in the body, right? So you've got an infection somewhere else, could be your heart, your liver, or something like that, and it ends up going into your lungs and gives you pneumonia. So pneumonia is typically classified by the causative organism that brought it. So the clinical classification, so you've got community acquired, hospital acquired, aspiration, and also ventilator associated. I think there's some others that are in the book that we're not going to cover, that multi-drug resistant, necrotizing, or opportunistic. They're in the book. You can look at them because I know you got lots of free time right now. But and so you've gotten to the end of Netflix, and so anyway, by all means, take a look at those. But these are the ones that we're going to concentrate on here for this course, and that'll get you through the course, the semester, as well as have you be successful on NCLEX. So let's talk about community-acquired pneumonia. These are the people that came in with pneumonia, right? So this occurs patients that haven't been hospitalized and they haven't been in a long-term care facility within 14 days of the onset of symptoms, right? So 3 weeks ago, they were in a healthcare facility. They've been home for 2 weeks. So that would definitely be a community-acquired. Typically, a lot of times these pneumonias can be treated at home or hospitalized depending on the patient condition. Empiric therapy is started as soon as possible. Empiric therapy is just therapy, antibiotics and stuff that are started based on what the physician might be seeing around in in their own area. So whatever they've been seeing is they're seeing an increase, an uptick, and maybe they tested the others. They found out this particular antibiotic works on it. And so they just start this on someone else automatically. So they use something called the curve 65 and then decide whether or not they're going to hospitalize somebody. So the curve is, CURB, right? And the 65, of course, is the age. So are they confused? Is their BUN greater than 19? Respiratory rate's high? Or systolic blood pressure is dropping, right? So, and then, of course, they're over 65. You get 1 point for each. And then typically, depending on how many points you get, usually 3 points or greater, they hospitalize you, as opposed to sending you home with medication. So, similar to the curve 65 is the pneumonia severity, the PSI. Same criteria, but it also includes gender, past medical history, whatever comorbidities, the lab work that you're getting, and some imaging studies. Imaging studies being x-rays or maybe a CT scan or something like that. And so they get put into 1 or 5 classes between 1 to 5, so depending on what it is. So then there's hospital-acquired pneumonia. So that happens when they got to us and we either had a hand in it, they acquired it while we were there taking care of them. Not present at the time of admission. Ventilator-associated pneumonia is considered a hospital-acquired pneumonia, obviously. And that occurs more than 48 hours after they got intubated, endotracheal, that tube down their throat into their lungs. So it's half is associated with longer hospital stays, increased costs, right? It just costs more to treat it. It's a little more virulent, a little bit tougher to deal with. Typically, the patients are sicker. They're already compromised in some other ways, and they have an increase in their risk of morbidity and mortality. Again, treatment is based on the known risk factors and whether it is an early or a late onset. So then there's aspiration pneumonia. So abnormal entry of secretions into the lower airway. So this happens a lot when someone is aspirating when they're eating, drinking. There's the overt aspiration. So maybe that's overt versus silent. I'm looking ahead to see if I talk about that later. So just in case I don't. So overt aspiration, obviously, someone takes a sip of water or swallows a bite of food or even their own oral secretions. And they do that and they start coughing. And so that's overt, right? We see it all the time. But there's something called silent aspiration also. You see this, it could be anybody, but you see it a lot in older people. So if you suspect that might be happening, and you suspect it because you're listening to their lungs, and their lungs sound kind of coarse, but maybe there's something else going on. There's not really a reason for that. So you might have them take a sip of water. Of course, they don't aspirate. They don't cough. They are aspirating. And you have them speak, right? Have them say their name or have them say, ah. And if it sounds gurgly, well, there's probably water that's in that airway, right? People that are having difficulty swallowing have a major risk factor. And of course, when we put an NG tube down, either with or without tube feedings, right? Because you think about that NG tube, is blocking the epiglottis from flipping back over and doing its job, right? So you see that a little bit more. So other types of pneumonia, aspirated material triggers that inflammatory response. The primary bacterial infection is the most common. Again, that empiric therapy where they're not really sure. Rather than wait and get a sputum sample to see exactly what deals with it. So they'll just give the thing that's working with most patients, right? Again, based on the severity, where it was acquired, and the probable causative organism, right? So the other thing that happens is aspiration of gastric contents initially causes a chemical, but typically that term is the non-infectious pneumonitis. So again, the pathophysiology, I stole this right out of your Lewis textbook, and so you can kind of see this is what happens with it. So check that out. So what do these patients look like? Well, typically a cough, fever, chills, dyspneic. They are maybe tachypnic. Their respiratory rate may be up into 30 or something like that. They're complaining about pleuritic chest pain. So they'll make chest pain. So you always want to say, okay, well, what hurts? Does it hurt when you breathe or something like that? So changes in mentation for older or debilitated patients, possibly related to hypoxia, because typically that's what's going on, right? They become hypoxic, and one of the first manifestations of that, or we start to see them getting confused, or they become agitated, or something like that. So some of the non-specific manifestations may be diaphoresis, fatigue, those myalgias, maybe a headache, something like that. So maybe they're a little bit anorexic, they just don't feel like eating. So physical findings, those fine or coarse crackles when you're listening to the lungs. So you get some bronchial breath sounds. This accompanies a change in the sound of the voice. So you might have them do a long E sounds like an A. So they're saying E and it sounds like A. Fremitus is a vibration in the chest wall that's produced by vocalization. And that dullness to percussion, especially if there's a pleural effusion that's present. And remember, a pleural effusion is just the water that's or fluid that's collecting in the pleural sac, right? And so there's that, or the pleural space. So some of the complications of pneumonia. So atelectasis, right? The alveoli collapse, right? This is not related to surfactant, but they do collapse due to a decrease in the pressure. Pleurisy, which is the inflammation of the pleura. You get a pleural effusion. We talked about that just the last slide. So fluid in the pleural space. Bacteremia, you get a bacteria set up in the lungs, and a pneumothorax. And of course, the pneumothorax is just air that has collected in the lung. So instead of this being water, it might be air. Of course, if it's going to be air, they're typically going to be higher up in the lung. So just because of gravity and water is heavy and air is not. Other complications are meningitis. The patient may get confused, may become drowsy. They can eventually go to an acute respiratory failure. And so that's when leading cause of death in severe pneumonia. Lungs can no longer handle that gas exchange for whatever reason. The fluid is built up, the mucus is built up in there. And so they're not exchanging oxygen for CO2. This is when we decide that we're probably going to have to intubate this person. Sepsis or septic shock happens when the bacteria from the alveoli enter the bloodstream, and that can lead to MODS, or multi-organ dysfunction syndrome. Some of the rarer complications might be a lung abscess or empyema, which is the accumulation of purulent exudate inside that pleural space. So the diagnostics, well, history and physical, what's been going on with you? Physical examination, listening to their lungs, looking at the patient in general, maybe performing a chest x-ray, get a sputum sample. So again, the culture and gram stain to identify which exact organism it is. That sensitivity will tell us, which antibiotic should we be using. And ideally, we want to get that sputum sample before we start antibiotics, but don't delay the treatment, right? If they can't give you a sputum sample right away, we're just not going to know, okay? So they get a CBC with a differential, so usually a white count greater than 15,000, and they don't have the presence of bands, and bands are simply the immature neutrophils that are in our bloodstream. And the pulse oximetry, and maybe get some ABGs to see what's going on with that. So it might be some further diagnostics. Patient doesn't respond, so now maybe we're going to do some blood cultures. Let's find out exactly what's going on in there. Might do a thoracentesis or a bronchoscopy with washings. I made these italicized and gave them an asterisk just because they could be used to diagnose or to treat, right? So they might do a thoracentesis, pull the fluid off, and that might be a treatment, but then they also might send the fluid down and get a culture and sensitivity on it and see what treatment do we need to start. Biologic markers are guiding those clinical decisions, so CRP or that procalcitonin, right? So get a pneumonia vaccine, right? There's a couple different ones. They're the PCV13, you don't need to remember this, PCV13 or PPSV23. Kind of depending on what it is. Some of them you get, and you have to get them again 5 years later as a booster. And some of the newer ones, you just get it one time. Typically, we're going to recommend them for patients over 65 years of age. But there's also, you want to think about the comorbidities. So someone has some other things going on with them. Maybe they're diabetic, or there's something else. They've got HIV or something like that. And so we're going to maybe have them get a pneumonia shot or a vaccine, even though they're only 40, right? It just kind of depends. So prompt treatment with antibiotics is a priority over anything else. Response usually happens within 2 to 3 days. The temp goes down, breathing gets easier, less chest discomfort. And then we'll do another x-ray in about 6 weeks, right? So maybe just make sure that this thing isn't coming back. So supportive care in addition to the antibiotics. So maybe we're going to give them oxygen for their hypoxemia, analgesics for chest pain, right? Nothing too strong. Just of course, kind of depends on how much pain they're in. Antipyretics, individualize their rest and activity. And by that, I mean, they don't want it to be a couch potato, but you can't make them run a marathon either, right? So you might have to have them go back and forth with rest and exercise, rest and exercise. And maybe that exercise is just ambulating, from the bed to the bathroom, right? Or maybe they are going to be able to walk down the hallway. So it's just kind of, you have to individualize that depending on the patient. There is no definitive treatment for the majority of viral pneumonias, and they're typically self-limiting. 3 or 4 days later, they kind of tend to resolve on their own. There is some antivirals for influenza pneumonia. So acyclovir is for herpes simplex, but oseltamivir or zanamivir, again, don't worry about those. Those will not be on anything like that. You're never going to hear about that again unless you're actually giving them. So we start with that empiric therapy based on we're not really sure what's going on, based on the likely what we're seeing in the community at the time. And again, you can't see it here, but it varies with the local patterns and then of antibiotic resistance, right? You should see improvement relatively quickly, 3 to 5 days. We start with their oral antibiotics and then maybe switch to oral therapy as soon as they're stable. And this is where you might be sending your patient home on antibiotics, and so you want to make sure that they understand they need to take the entire course and don't stop halfway through. So nutritional therapy, right? So we want to make sure they stay hydrated, and that's going to thin and loosen those secretions so they're able to get them up. So again, you're going to adjust this for older adults, those with heart failure, and anybody that has a pre-existing respiratory condition, right? So we want them to eat high calorie and small frequent meals. Again, and if I don't say it again, when you can eat or breathe, and you usually can't do both at the same time. So think about that when you're having dinner tonight and kind of go from there and see what you see. So high calorie, small frequent meals. And of course, we're going to monitor them for weight loss, right? So they just don't feel like eating, and so that tends to slow it down a little bit. So nursing assessment, right? Again, that prior health history. Do you have a history of cancer, COPD, diabetes? Looking at their nutritional status. What antibiotics are you taking? What antibiotics have you taken? Any chemo or immunosuppressants, whether that you're taking, any recent abdominal, thoracic surgeries. You'd be surprised how often these things, people don't think to tell you. They're not being mean. They just don't think to tell them to you, right? Have you been intubated lately, right? And, you might ask somebody about that, and, oh, yeah, I was intubated last week or at a different hospital. I'm like, really? Okay, well, there you go. Thanks for that. Or are they on tube feeds, right? So, again, that's subjective data. Are you a smoker? How much alcohol do you consume? We need to get comfortable asking that question. How many alcoholic beverages do you consume? Respiratory infections, nutritional intake. How's your diet? Are you eating normally? Is it normal for you? Your activity, dyspnea, and then of course cough and pain. So are they running a fever, right? How high is that fever? Are they restless or lethargic? Maybe we're worried about their oxygen status. Maybe their chest hurts and so they're splinting. Maybe they're tachypnic, they've got rapid breathing. And looking at there for asymmetric chest movements, right? So asymmetric might be sometimes like a flail chest where one side is rising more than the other. Or maybe they're even doing that kind Stokes, right, where they're, and then, those kind of things. Or are they using accessory muscles, right? Are they happen to use that? We'll talk about it with COPD next week. But are they assuming that tripod position to try and open up their lungs a little bit? So objective data continued. So crackles, a friction rub. Friction rub is just simply as they take a deep breath, you can almost hear the lungs sliding up against the pleural sac. You get an increase in your tactile fremitus. So again, they state 99 or 123, right? So it can indicate how consolidated their lung tissue is. And by consolidated, I mean how much fluid might be building up in there. How much sputum are they producing, and what color is it? Tachycardia and changes in mental status. I guess I can't say that enough because when you start to get hypoxic, restlessness, apprehension are one of the early signs of inadequate oxygenation. So nursing implementation, so health promotion, right? We want them to start having good habits, right, and reduce the risk that they're going to develop pneumonia in the future. Hygiene, they've got to learn how to start washing their hands using the alcohol stuff to keep your hands, the bacteria down. Adequate nutrition, adequate fluids, get enough rest. I know a lot of us, tend to not sleep very much. But if someone has already had pneumonia once, we want them to not get it again, so maybe get more rest. Get regular exercise to maintain a natural resistance. This compress knees into your elbow, not your hands, is pretty commonplace now, but you might be surprised at how many people aren't aware of this. We want them to avoid cigarette smoke, not just their own smoking to quit smoking, but maybe someone in the house smokes, right? That secondhand smoke is almost as bad as the primary smoke. Prompt treatment of any of your upper respiratory tract infections. So make sure that if they start to feel anything at all, that they present to their primary care physician right away. And again, get a flu shot and a pneumonia vaccine. Those things are really going to be saving you. So preventing pneumonia in at-risk patients in the acute care setting. So they're in the hospital with us, and we want to stop them from getting that hospital-acquired pneumonia. So proper positioning to prevent aspiration. So that happens a lot. People, they're kind of relying in bed. You're passing the morning meds. You're giving them pills with water. They're going to lay in bed to eat breakfast or something like that. What they really need to be doing is encouraging them to sit up. You can't make them sit up, but you can strongly encourage it, right? Elevate the head of the bed 30 degrees or even more, and making sure they sit up for all meals. Out of bed if they can deal with it. Make sure you're repositioning that patient every 2 hours, right? So if they're just kind of lying there, always on their right side, let's make sure we get them back over onto their left side and keep whatever fluid might be in their lungs, keep it moving back and forth. And then, of course, with the VAP, strict adherence to that ventilator bundle to help prevent VAP. So preventing pneumonia in those at-risk patients in the acute care setting assists with eating, right? Maybe we need to sit there and feed them, right? Maybe we need to make sure that we're chopping their food up small enough and making sure that we're watching them when they're drinking. Can they handle the thin liquids, right? Do we need to maybe get a speech consult, have them come and see if they are aspirating? Assessing for the gag reflex. Typically, we just have them sip something. You can also use a tongue depressor or a swab and just kind of swab, and we're not going to gag them, but just make sure that that's back, right? Early mobilization, make sure they're getting out of bed, right? The more you lay in bed, that's just an invitation for pneumonia to get started. And then have them use that incentive spirometer. I think most of you are pretty good about it. I think the first semester has done a really good job of teaching you guys how to teach a patient to use an incentive spirometer. But I would say the important thing that if I see patients do anything wrong, mostly, is they inhale too quickly. And they focus on the amount. And it's really, the amount's important, but not as important as doing that low and slow inhalation. And then twice daily oral hygiene. That's another thing that we kind of tend to, forget about. We're so busy in the hospital. And we just don't think about, having them brush their teeth. So try to stay on top of that too. So assessing your patient frequently, prompt initiation of antibiotics. Once they're ordered, don't delay that antibiotic treatment while you're waiting for a sputum sample. Get them on oxygen right away. We talk about, can you put oxygen on a patient without an order? You can if it's going to save the patient's life. If you're in a hurry and it's getting really bad, just put the oxygen on them and then call a physician right away. I'm not saying put oxygen on them and forget it, but don't wait for a physician's order. Staying adequately hydrated and having adequate nutrition. Again, it's a high protein diet for this kind of thing. So interprofessional collaboration, we're going to get the respiratory therapists and those physical therapists involved. That can be lifesavers in helping us deal with our patients. So the acute interventions that we might use, breathing exercises, having them being able to sit forward, take good deep breaths, having that incentive spirometer to help mobilize those secretions. And again, these are adult learners. We have to tell them, why are you doing this, right? You don't want to add pneumonia to your list of troubles of what you're in here for. So let's keep this going, and this is kind of going to be your best friend. Early ambulation, getting them out of bed, keeping them moving, getting them at least up into a chair at the minimum. some therapeutic positioning, having them rotate back and forth if they're not able to sit up. And again, pain management. If they're having pain, they're not going to be taking those good deep breaths. So let's keep their pain under control. All right, so patient teaching for home care. So, and again, emphasize the need to take that full course of your antibiotics at home. And then maybe mention to them about the drug-drug and drug-food interactions, right? So you're pretty familiar with no grapefruit juice with statins or calcium channel blockers. So making sure they get adequate rest, adequate hydration, avoiding alcohol and obviously smoking. Get yourself a cool mist humidifier with them in a very dry environment, especially in the summertime. And I think in the wintertime too. So, and then chest x-ray, and then keep up with those vaccinations, right? Just make sure that we're staying on top of that. So the outcomes and goals that we're looking for, clear breath sounds, normal breathing patterns, right? No sign of hypoxia. Chest x-ray comes back normal, white count has come back into range, and there's no complications that are related to whether or not they've gotten pneumonia. So the patient will have an effective respiratory rate, rhythm, and depth. Lungs will be clear. They'll report pain control is under control. Their oxygen sats are 92 to 95. There's no adventitious breath sounds, and clear sputum from the airway. So that's it. We're going to now, I guess we'll talk about tracheostomies. All right, so tracheostomies. So what is a tracheostomy? So surgically created stoma or opening used to establishing a patent airway for the patient to breathe through. Maybe we need to bypass some kind of airway obstruction that might be higher up, facilitate the removal of secretions from down in the lungs, permit long-term mechanical ventilation. Not everyone gets off a vent. Sometimes people can take 6 months or even a year. Maybe some of you that have been out in some of the skilled nursing facilities, they might have somebody that's on a vent weaning protocol. The major complication then with the tracheostomy, and this might be important later, is a complication is that it bypasses the nose and the throat. So they lose that humidification of air. They're no longer filtering the air that's coming through. I mean, if you look at it, it's just straight shot, right? It's just a straight shot wherever you're breathing. It goes right on down in there, so they can develop that pneumonia or influenza. So the advantages of a tracheostomy versus an ET tube. So going back to it, so why do we put a tracheostomy in somebody? Well, most times, I'll say most times, not always, but most times it's because they got intubated through an endotracheal tube, which goes down through their mouth and down into their trachea, but they're not able to get off the vent. And so within 7 to 10 days, we want to make sure we get that taken out again. Just the effects of the balloon from the ET tube, it's quite a bit larger. It places more stress on the trachea. Tissue starts to break down, and now we have a whole different problem. So usually within 7 to 10 days, if they're not able to get off the vent, they will put a trach in them. So tracheostomy is a little easier to keep clean. You get better oral and bronchial hygiene because, with an ET tube, you're not really able to clean their mouth as well. Patient comfort is definitely increased, and the long-term risk to damage to the vocal cords is much lower. So you can kind of see, this is what a tracheostomy looks like. This is, of course, the side view. So there's the epiglottis that kind of keeps us, food and water going where it's supposed to go, and air coming down where it's supposed to go. So you can see that it's placed above the vocal cords. So an ET tube would come down here and go down through into here and go actually maybe a little bit even further. So this is where it sits. This is a pilot balloon, and we'll talk about, I think, I'll show you a few more pictures of them. But you can see this is the balloon that gets inflated, and so that maintains a seal, right, between down in the lungs and the upper airway. So the different parts of a tracheostomy tube, everybody, I think we've already done the skills lab for trach, so a lot of this might be kind of familiar, so maybe I'll kind of speed my way on through this. You all did some trach care for somebody, so And I think the one thing most people ask about is this obturator that should be kept at the bedside. So what that does is it gets fit into here, and this then comes out down here. And so if you ever have to reinsert it or the initial insertion, there's that obturator is there to kind of help that go through. So this is a video. You can watch this. This is I don't even know what that's showing you anymore. So good luck with it. All right, so bedside insertion, right? So if you're going to be the one helping with this, and we do this in the bedside in the ICU all the time. So, and I got some pictures I'll show you here of what it looks like. But typically the nurse is responsible for recording the vital signs and making sure their IV is patent. Used to be we would administer any analgesia or sedation. Sometimes some hospitals want the physician to be the one pushing those. You'll still be the one to draw them up and hand them over. Depending on your situation in your particular hospital, it may be you pushing it, it may be the physician. Making sure that bedside suction is hooked up and ready to go, and we position that patient in a supine position. So here it is. This is called a Blue Rhino. That's a brand name. So this is someone's neck right here, and what you can see, they've made a small incision here, and they're putting in here. This is called a guide wire over which they'll put a dilator. So. And this basically is the dilator, and sometimes we call it, it's just basically a sharp stick. It's going to go through there. So what they're doing is they're using that. You can see it gets larger as it goes up. They go through, and they're making the opening larger. So once they get it down, you can see quite a bit. You can see that it's really gone down quite a bit. Right? So again, this is going down. Now that tip is down inside. And then once they remove that, and there's this guide wire stays in there, and then the tracheostomy gets placed over that, right? And then that gets pushed down right into the opening. And there it is in place, and it's got a vent hooked up to it, or a bag mask valve or something like that. So nursing management is somebody with a tech. So the obturator is removed and kept at bedside. We either tape it to the head of the bed or to the wall behind the head of the bed. The cup or that balloon that we talked about is inflated. We auscultate for air, make sure air is going into both sides of the lung. Tracheostomies are typically sutured into place and then secured with trach ties. So I won't go through a lot of this. You just went through it, but you can look this over in case you didn't get enough information when you were in your skills lab. So, and just kind of go from there. For suctioning trachs. So suctioning a trach, these are the steps that you'll go through. I'm sure you went through that in the skills lab. Limit that suction to 10 seconds, rinse it with sterile water in between each pass, allowing the patient to recover, and then auscultating for changes at the end, right? Did you do a good job? Did you get everything cleared out? If their lungs sound clear, you did. If not, you might want to give them a break and then come back maybe in 10 minutes or so and then suction them again. So for suctioning, again, you guys have already had this skills lab, so it's kind of out of order now. But anyway, here they are suctioning through just through a regular trach. And this patient is on a ventilator, and that's that inline suctioning that they're doing. So some of the equipment, some of the things that might happen to you is the acronym trach. So trach ties, keep those ties secure. We use mostly Velcro now. For resuscitation, know the process. Don't be afraid to shout for help. Check their breathing and know how to connect that bag mask valve up to it. Keeping the airway clear using that correct suctioning technique. They should be cleaned at least once a shift, and then PRN. Typically, the newer the trach, or sometimes what's going on with the patient. How sick are they? How much mucus are they producing? Sometimes they've got to be trached, and some of you have told me stories where patients want to be suctioned every 5 or 10 minutes, right? And that seems a little excessive, but typically you want to make sure you're cleaned in at least once a shift, and again, more often if it's needed. Looking at the skin underneath that faceplate, making sure it's not breaking down. Keeping the tube clear of water from water droplets, so if you're getting some humidity, just make sure that the water, because again, it's a straight shot down into the lungs. And in emergency, having that proper equipment close by. One of those being the obturator, making making sure it's right there that it's ready to go in again. So again, hey, I use it. I think I was telling everybody in my group when I was doing the skills lab, I was like, hey, don't do that. But when you're out in practice, it's, you're leaning over, you're trying to make sure you're just putting it in there, and you don't want it to touch the sides, and patient coughs, and you don't want that to be you. So tracheostomy care, the tube with the inflated cup, and some are cupped and some are cupless. The inflated cup is used for someone that has maybe an aspiration risk or they're on mechanical ventilation. So you inflate the cup only with enough pressure to seal the airway. This is called a manometer. And so that hooks up to that pilot balloon, and it should read between 20 and 25 millimeters of water. Right? So some people, I think last semester, somebody asked, water or mercury? No, it is water for this. A lot of times, like blood pressure, it's mercury. But for this, it's water. So the potentials for dislodgement. It doesn't happen frequently, but it's pretty exciting when it does. Retention sutures, so the pre-ends are taped to the skin, and they leave the sutures in there until the stoma is starting to heal pretty well. Most dangerous for those first 5 to 7 days. And the precautions, again, we have a whole replacement tube, the entire brand new setup, brand new in a box. So that if that trachea, if it does pop out and it gets coughed out, sutures become loose and it hits the floor, we're just going to grab a new one. If you don't have a new one, by all means, stick that dirty one back in. We can fix sepsis, but we can't fix dead. Don't change the ties for at least 24 hours, and sometimes the physician wants to do that first, both the ties and the first tube change. So if it does come out, heaven forbid, immediately call for help, right? Hit that, I don't know about hitting the code blue, but if somebody doesn't come right away, I'd rather hear you hit a code blue and they got in there to fix that than, no one came and 20 minutes later you're still looking for help. So first thing you can do is, if it's possible, spread that opening with a hemostat and insert the replacement tube using the obturator. Make sure you remove the obturator. You can also insert a suction catheter, just even if it has to. You can always stick a Yankauer in there if necessary to guide the insertion of that replacement tube. Some students say, I don't know what a hemostat is, so I threw in a picture of a hemostat. Some are straight, some are curved. They come in handy all day long, so it's always a good idea to have them in your bag, in your pocket. They come in handy all the time. So accidental dislodgement if a tube can't be replaced. Well, look at your patient. Maybe they're fine. Maybe they're sitting there, they're breathing, and they're like, what are you freaking out about? I'm like, well, you're freaking out because you lost your trach. But I'm okay. Well, let's look at them. So you might get them into a semi-Fowler's position. If they do have severe distress, we cover the stoma with a sterile dressing and ventilate that patient with a bag that's a bag valve mask until help arrives. So in that, of course, that bag mask valve or bag valve mask covers their mouth and their nose. So there is some swallowing dysfunction for patients that have trach, especially if the cup is inflated, just because it is pushing. Remember, the trachea sits right next to the esophagus. And so people can't eat with these, but they might need to help remembering that you should be chewing your food up really well, or maybe only chewing soft foods or something like that. Keep in mind, you don't want to put that big old diet potassium pill down somebody that's got an inflated cup and they're having trouble, difficulty swallowing. Maybe see if you can get the pharmacy to switch it over to a liquid that they can drink. Clinical assessment for swallowing ability and aspiration risk. Sometimes if there's no risk for aspiration, you need a doctor's order for this. They might leave the cup deflated or replace it with a cupless tube. So some of the techniques for trach patients so that they can speak. So if some are spontaneously breathing, you can deflate the cup. Again, this is all with the physician's order, allowing exhaled air to flow over the vocal cords. If you think back to that picture at the very beginning, remember the balloon or the cup is down below and the vocal cords are above. And if you deflate that balloon, air can move forward over it and then over through the vocal cords, and that's how they're able to speak. There are also some specialized trach tubes that are called fenestrated. So fenestrated, you probably saw this in your skills lab. It has that hole in it, so air will come up through the bottom of the tube, go pass through that hole, and then pass over the vocal cords. There's also something called a speaking valve. Typically, they're called Passimir valves, and I think I'll show you them here in just a second. So those fenestrated tracheostomy tubes. Remember now, fenestrated means it's got a hole in it, right? So that's only for patients that can swallow without a risk of aspirating, right? The holes in it allow the air to pass from your lungs up over the vocal cords through your mouth and nose. Well, the nice thing about that is they kind of breathe normally, right? It's almost like they don't have a trach tube, right? Typically, when this is going on, these might even be close to having their trach removed and the opening closed up again. They speak using their vocal cords. They're able to cough out any secretions through their mouth. Again, it can come out through the trach as well. And maybe used as a step before, again, that removal of that trach tube. So if you didn't see it in Skills Lab, which I'm sure you did, these are two different types of fenestrated. This is one larger hole, of course, for smaller ones. The thing you want to make sure you're doing is, if your trach is a fenestrated one, that you get to make sure the inner cannula has the same holes in the same location. So typically not a big deal, but, hey, better safe than sorry, yeah. So this is what we're talking about, those speaking valves, those Passimir valves. A thin diaphragm that opens on inspiration. So what happens is, as they're inhaling, it allows it to open, right? And so air can easily go in, but then when they start to exhale, as in when they're speaking, it flips forward and occludes this thing, right? So air kind of only goes one way. It goes in through here and then down into their lungs. And then as they're speaking, it can't go this way, so it comes up and they're able to speak, right? The other thing you see patients do is this Passimir valve isn't on, and they take their finger, their thumb, and this is nasty, but they just occlude it themselves, right? They take a deep breath, put their finger over this, and then they can speak, right? The problem with that is the finger's probably not sterile, right? And so they're just, again, increasing the risk that they're going to get bacteria down into their lungs, and then they're going to get what's called hospital-acquired pneumonia, and then we're paying for that. So anyway, I think that's it for trachs. If you have any questions for any of this, of course, just shoot me an email, and we'll kind of go from there. All right? Let's wrap this thing up, and let's talk about TB a little bit. So TB, tuberculosis, not a huge deal here in the United States, but real common in other countries. So it's an infectious disease caused by the Mycobacterium tuberculosis, right? Lungs are the most commonly infected, but tuberculosis is aerophilic, which means it's oxygen loving. That causes it to have an affinity for the lungs. But you can get tuberculosis in any organ, right, including the brain, kidneys, or even bone, right? So a third of the world's population has TB, right? 10 million people get it. These figures are probably about 3 years old, and 1.6 million people die from TB, right? So it's a pretty big deal in the rest of the country, the rest of the world. It's a leading cause of death in patients that are HIV positive or have developed AIDS. Prevalence is decreasing in the United States, so it's becoming less, but that's just because we're really on how well we deal with it. So, who are those that most at risk? So, homeless people, right? They tend to congregate in areas along with each other. One person has it and they share it. Residents of inner city neighborhoods, right? They're packed very tightly. Foreign-born persons, just because it's more common in other parts of the world. Living or working in institutions, that includes us, right? Those healthcare workers, but also guards or maybe prisoners. People that are IV drug users, those are poverty-stricken. Maybe they have poor access to healthcare. And definitely those that are immunosuppressed. So etiology, pathophysiology, it's spread through airborne particles. And that's why you definitely need an N95 mask for this. This is not droplet. This is airborne. So you've all seen, dust floating in the air through the sunlight, right? That's the same thing with TB. It's so tiny and it's so light. It hovers in the air, right? Minutes to hours, right? And so you accidentally inhale it, and then it can set up into your lungs as well. So it's not spread by touching, sharing food utensils, right? This is not what's happening, right? And that's because those little particles have to get well down into your lungs in order to get down there. So typically, like sharing a fork or a spoon or even kissing or other physical contact, remember it's the aerosolized version of that TB bacteria that gets down into your lungs, and that's what causes you to develop tuberculosis. So classifications from 0 to 5. So 0, no TB exposure. 1, and they're exposed, but they don't really have an infection. So if it's latent, number 2, you might get a reaction to a TB test, but the X-ray is clear. You don't have any signs or symptoms, right? So it means you're infected, but you don't currently have a disease. For 3, you have TB and it is clinically active, right? And where tissue is being damaged, especially if it's lung tissue. Number 4, TB not clinically active. That means you had it in the past, but it's currently not active. And number 5, TB is suspected. They're working you up for that. I will go into some of the things that we do. So the diagnosis is pending. We don't really know what it is yet. You can stay at a 5 for up to 3 months, right? And if it doesn't come back positive, then you're either going to end up with a 0 or a 1. So again, I don't think I put anything on the exam about this, but just kind of know that it's classified and, depending on the number where they're at. So latent tuberculosis infection. So typically these patients are asymptomatic, right? So if you have a pulmonary tuberculosis, it can take 2 or 3 weeks before you develop those symptoms. You get an initial dry cough, and it eventually does become productive. Constitutional symptoms are a group of symptoms that can affect many different systems of the body, right? So you get that fatigue, malaise, anorexia. Low-grade fever, night sweats is one of the things that people complain about most often. And that dyspnea and hemoptysis are late symptoms. So by the time they have these, the disease has probably progressed pretty well. So the clinical manifestation, so cough becomes frequent. Hemoptysis not common, right? It's part of the advanced disease, right? And dyspnea is pretty unusual too. But you can also present more acutely, right? So you get a high fever, those generalized flu-like symptoms, that pleuritic pain that people complain about, a productive cough, and then crackles or adventitious breath sounds, so that you might hear. So again, TB can affect any organ system, right? And the immunosuppressed people and older adults are probably less likely to have a fever and the other signs, right? So they don't always have that same high fever or those close sounding lungs or some of those things that we were talking about on these clinical manifestations. So some of the complications of pleural TB or lung, right? So chest pain, fever, you can read the complications. You can develop a pleural effusion, which bacteria in the pleural space can cause that inflammation. And then the pleural exudates, or empyema, is what ends up there, which is empyema. Large numbers of tubercular organisms in the pleural space. And so bacteria is set up in that pleural space. So diagnostic tests. So TB test. This is what everybody gets quite a bit, right? A Manitou test, purified protein derivative as injected intradermally, access for an induration. So this is one where you've got to go back and 48 after 48, but before 72 hours have passed, right? And they're looking for the presence of the induration. And again, I say it's not the redness, right? So the fact that it's red is not the issue. It's how well is it raised, so at the injection site. So that would indicate the development of the antibodies that are secondary to an exposure, right? So there's 2-step testing recommended for healthcare workers and those of us at Banner. We get a blood test. They don't do a TB test anymore. They come in and they draw a small amount of blood, and they're looking for the TB allergens that are in there, the antibodies that are in there. Patients that receive the BCG vaccine, that's real common in Europe and some South American countries. So they get a vaccine against that. They will always have that positive Manitou test, right? So once they have that, same thing for a healthcare worker that gets exposed to TB. We stop doing those because they're always going to come back positive. So this is what it means by the induration. So this is a negative result, right? You can see that it's red. Really what they're looking for is see how it's kind of puffed up, but then with the fact that there's redness around it. And that is often the case, but it might not be. That's the thing that we're looking for. The interferon Y gamma release assays are another one that we use. They can do a chest x-ray, but again, that might appear normal, right? You may not see anything. They have to do bacteriologic studies, and that's required for the diagnosis. The thing that once somebody is worked up for TB, they figure they had TB and they're waiting for them to be able to be released back out in the wild. This is pretty important. So they need consecutive sputum samples obtained on 3 different days. So that's 3 different days, 3 24-hour periods later, right? Not a morning, an afternoon, and an evening, okay? Just got a message about my network connection, which usually it's smoking, but we'll see what happens. So again, hospitalization not necessary for most patients, right? They're infectious for the first 2 weeks after starting the treatment if their sputum is positive, right? Again, once they get those 3 tests back negative, then they're free to go out and move in the wild. Drug therapy is used to prevent or treat all active diseases. We need to monitor compliance, and that's kind of a problem. Sometimes people, they feel like they feel fine, and they don't want to take their medications, and so they just ignore it, right? So sometimes they have to get the health department involved, and you have to go down there, and they actually watch you take your pills. So active disease. So the treatment is aggressive. So 2 phases of treatment. So Initol for 8 weeks, the initial for 8 weeks, and a continuation for 18 more weeks. And that's a 4-drug regimen, right? And this is the medication. So I will tell you that you probably want to pay attention to these medications for the active disease, but also for the ones that are maybe a healthcare worker might get, and I'll show you those on the next slide. So they have to be taught about the side effects of these medications. So side effects are typically, they're really hard on the liver. Right, so they need to avoid drinking. Isoniazid, right, is the thing that they get most often. So again, avoiding that alcohol. Alternatives are available if somebody develops a reaction, but really those ones are the best. So that directly observed therapy. So we talked about that. Some patients, they don't want to, they're not compliant, and that's a major factor, and that's how it spreads so easily. And so it requires watching the patient swallow the drugs. They've got to go down to the health department, or a healthcare nurse might go by their office or their home every day. And that's the way that they make sure. So they might have to go to the health department again. Sometimes they'll go to the home. So latent TB infection. So this is the one that you might have a healthcare worker that developed a positive TB test. And so they'll be treated with that isoniazid for 6 to 9 months, right? And we're going to make sure they know about, hey, just in case, I mean, they're nurses, they should know, but maybe they don't, they forgot, they never got it. Hard on your liver, so make sure they know about that. So HIV patients should take it for 9 months, right? There's an alternative 3-month regimen, so for those patients there. So the history. So for the nursing assessment, what we want to do is we want to find out where they've been, right? Have they recently been incarcerated? Have they been in jail? Have they recently homeless, lived in a homeless camp, right? So the physical symptoms they might have is a productive cough and those night sweats. That's something that you see real frequently, night sweats, afternoon temperature elevation, and weight loss, right? And crackles over the aspices of the lungs, and maybe we'll get a sputum collection, right? I want to make sure we get that and take a look at that and see if it actually is TB. This is saying acute care. Again, you'll be able to see these, everything here, once I post this up on D2L for you guys. Or maybe I think I did the printer friendly, but I'll post this one as well. So airborne isolation. So these people go into a single occupancy negative pressure room, right? And so you'll see this gauge outside the room. And so it's going to have a minus number. Negative pressure room, they do 6 to 12 airflow exchanges per hour. And you're like, well, where is it going? Well, it goes through a HEPA filter and it goes right out into the air, right? So again, that HEPA filter catches most of them, or if not all. And what does escape is usually so small. They get an immediate medical workup. And again, they start that appropriate drug therapy. So I guess I left this slide in here. It used to be people freaked out, oh, it's an N95 mask, right? but I used to tease people, but that's what it looks like. But now everybody's seen them on the news, so it's not funny anymore. So there's an N95 mask, and these are PEPPers, positive air respiratory. And so what they have, there's a filter that's back here, and this is what I wear when I'm at work, taking care of those COVID patients right now. Last Saturday, they're killing me with this. So anyway, it's that filtered air, it gets constantly pushed here, and it's kind of a positive airflow. So air's only coming out, right? Only coming out this way, right? So nothing goes the other way. Now they've got them where they got this whole shroud over your shoulders. And I'm like, I guess that's kind of cool. So we got to teach these patients that they shouldn't be spreading this around, making sure they cover their nose and their mouth with tissue when they're coughing, sneezing, or producing any sputum, washing their hands, and can spread the disease as long as the facility can be coughed into the air, right? So if you need to transport your patient to X-ray or CT or something, you just put a regular mask on them, right? N95s, they're really only for people that go and you got to be fit tested for an N95, and we're not fit testing patients or students for that matter. But and you want to identify and screen their close contacts, make sure that they understand what they're up against. So again, we're emphasizing the importance of complying with that drug regimen. One thing that if a patient's being discharged, they're going to go home with prescriptions. Make sure they have access to the medications before discharge. So otherwise, they're like, yeah, I couldn't get it filled. And so they never get the medications, and they're out there sharing TB with everybody. So that's going to be important to remember later, too. Teaching them how to minimize the exposure to close contact. So they should sleep with the windows open. Maybe not so much here in Arizona when it's 100 degrees at midnight, but still have them ventilate the rooms, put a fan in the window and keep the air blowing out. Until that sputum is negative, and usually by the time they're released from the hospital, it is negative, they should sleep alone, spend time outdoors, and minimize their proximity to people and avoid public transportation. And maybe emphasize the importance of those treatments and complying with those treatments. All right, so we're going to wrap it up here. We're going to talk about bronchitis for a little bit. A couple of different things. There's chronic and there's acute. So chronic bronchitis, the presence of a cough and sputum production for at least 3 months in the last 2 consecutive years. So it used to be bronchitis was considered part of COPD, but now it's its own independent disease, right? They frequently go hand in hand, but you can have bronchitis and not have COPD, right? So I think that's the reason that they've kind of separated them out. You get an excess in the mucus production, resulting in a chronic productive cough. And that's one of those things that people with bronchitis complain about the most. So how does that happen? So it's multifactorial, right? So an increase in the number of mucus secreting goblet cells, right? And the goblet cells are the ones that clear the lungs and the trachea and the airways with mucus to get rid of. And the mucociliary response kind of keeps it moving up into your mouth so you can cough it up and spit it out, right? Don't swallow it. So that's what's happening with those. So you get an enlarged in those submucosal glands. The dysfunction of the cilia, so again, it's not moving things up and out very well. You get a stimulation from the inflammatory mediators. So chronic bronchitis. So pulmonary hypertension happens, and this we're going to go right into core pulmonale, and we'll talk about this in COPD as well. Pulmonary hypertension may progress. It leads to the hypertrophy of the right ventricle of the heart, which now we have core pulmonale, so that right ventricle dilates. You start to have right-sided heart failure. And due to that extra work of breathing, you might even see a pulmonary artery enlargement on the x-rays. So if you're looking at an x-ray, you might even see an enlarged right side of the heart or an enlarged pulmonary artery. I would say it 3 times, but hopefully you got it now. So underline that slide. So acute bronchitis, conversely from chronic, it's usually self-limiting, right? Bronchi in the lower respiratory tract, right? It's usually caused by viruses, and it might get triggered from either pollution, dust, maybe inhalation of chemicals, smoking, maybe somebody is smoker in the house, or asthma, right? So can trigger it. So with acute bronchitis, the cough is the most common thing that you're going to see. So those clinical manifestations. So you get clear secretions, headache, fever, malaise, hoarseness, those myalgias. So chest pain, that kind of thing. So you might see some clubbing of the fingers. This is going to be more, probably more likely with chronic, but it could happen with acute as well. So the diagnostics for acute bronchitis, well, it's based on the clinical assessment, right? You might have normal orienting crackles in the lung, wheezes on expiration. Chest x-ray, again, is most often normal. So acute bronchitis treatment is typically just supportive, right? Cough suppressants, making sure they're drinking enough fluids, maybe use a humidifier. They can use bronchodilators, useful if the patient develops a wheeze. We want them to avoid any primary and secondary smoke, again, washing their hands frequently. And if they're getting acute bronchitis through the influenza, these are the medications that you might typically say. So again, a close relative, they did some research on it. If you haven't heard this before, you're going to hear it a lot. So, and I think that's it. I guess I'm gonna put up some questions. These are clicker questions. I didn't know I was gonna use these, but let's go ahead and go through them, right? So we'll see if it still works. When assessing a patient who's just developed from an automobile accident, emergency department notes tachy and absent breath sounds over the right lung, which intervention might you prepare? Well, no lung sounds on one side, right? So they probably have a pneumothorax. And so they're going to hook up a chest tube. I don't think these are even your questions. I guess that was just a bonus question or something. Hey guys, thanks very much. I'm sorry, I've probably droned on and on and on. I apologize for that. I get to do this again for respiratory and then for intra-op. So I really appreciate you taking the time, sticking with us, and helping us get through this. We really appreciate your help with that. All right, you take care.